Good evening, Dr. Dulari.
Good evening, sir. Sorry, my computer started to do some update suddenly.
No worries, and just in time. And Srihari is also on the line. We'll wait for a few more minutes.
Yes, yes.
There are 10 participants joined. Total 10 we are. Dr. Sunil Narayan will not be coming because of some loss. His father expired or something, so he's not coming. So
Sir, please start.
okay. I think we'll start then. Good evening, all. Today we are going to have an interesting journal club, and the journal club will be presented by Bharati Hospital, and Dr. Srihari will be presenting, and Dr. Dulari Gupta will be discussing this journal club in detail. So I welcome you all for this month's journal club. For a few months we were not regular, but now from New Year onwards, every month there will be a journal club, and Dr. Sunil Gajre told that we should have a case also. So we have a short case presentation, and by the time others also will join, and we can continue the journal club. I hand over the proceedings to Dr. Dulari for conduct of this session.
Good evening, everyone. And I would, at the onset, like to thank Gurthi sir and Dr. Sunil Narayan sir for giving us this opportunity to present a journal club in iron stroke subsection. So I will like Dr. Srihari, who is our senior resident in neurology, to present a short case which we have thrombolized and a little different from the article we are discussing, but a case followed by an introduction to the article. Dr. Srihari, could you start?
Sharing my screen. Good evening, everyone. Is it visible?
Yeah, it's visible.
So first we have a case of a 33-year-old male who was a hypertensive, had past history of ischemic heart disease, who had underwent angioplasty 10 years back. And he was not on medications, a chronic smoker and alcoholic who came with sudden onset loss of speech since 2 hours, sudden onset giddiness, and it was immediately followed by heaviness of tongue and loss of speech. There was no history of LOC, trauma, dysphagia, fever, vomiting, or seizures prior. On examination, he was having tachycardia. Blood pressure was 168 by 72 millimeters of mercury. Saturation was 96%. Initial examination in the emergency room revealed a GCS of E4. Verbal response, he was aphasic, and M6. Patient had motor aphasia. He was obeying very simple commands only. Pupils are both reacting to light. He had right hand grip weakness of about 75%. Right plantar was mute. Left was flexor, and NIHS score of 8. So we went ahead with our CT stroke protocol. Initially, we did a CT brain, which showed an aspects of 9. And then the CT angiography was done, which showed a left MCA M2 occlusion. And then we went ahead with thrombolysis for the patient with connective place. His blood parameters were normal, apart from a serum homocysteine that was 39.5. An RBBB, the 2D echo was done, which showed an EF of 35% with LV hypertrophy and LV apical clot. 24 hours post thrombolysis, we repeated a CT scan, which showed no hemorrhage. This is the image. After consulting with the cardiologist, they advised anticoagulation, beta blockers, and diuretics. The patient was started on low molecular weight heparin on day 3 and followed by DSA, which showed multifocal occlusion of branches of superior and inferior branches of left MCA with TK2B recanalization. The patient's renal Doppler was normal. He was started on speech therapy and physiotherapy, and he was also started on oral anticoagulants, that was apixaban, on discharge with single antiplatelet therapy and statin. Currently, the patient is on follow-up, and he is currently MRS 0 at 3 months.
So we have shown this case for a young patient who earlier had ischemic heart disease with an LV clot, who presented with an acute stroke with severe motor aphasia, NIHS of 8, received thrombolysis and improved very well, and required lifelong anticoagulation after that. So this is not a patient with atrial fibrillation, which is what our journal article today is about. So, Gorthi sir, would you like to add anything else to this, or should we go ahead with the introduction to the journal article and the article?
I just would like to invite all the faculty who have joined the journal club, and as a prelude to the journal club, we just waited for others to join, so we presented a small case. LV clot with thrombolysis is a very dicey situation, and we had burnt our hands when we didn't do echo, and we were given thrombolytic therapy with disastrous consequences. So whether to do echo before thrombolysis is a debatable issue, and so far there is no guideline, but one has to be very careful. I think we'll go ahead with our. You can give the introduction about the article and tell why we are doing this. Then he can present the article.
Sherry, do you want to give a background to the article?
Yes, sir. So our article for today, the discussion is on apixaban for stroke prevention and subclinical atrial fibrillation. So I'd like to speak on stroke risk stratification and atrial fibrillation initially. So this on screen, you can see the CHADWA score. So here we have cardiac failure, hypertension, age more than 75 years, diabetes, stroke, vascular disease, age 65 to 74 years, and sex category for females. All being scored 1 except for age more than 75 years and stroke. So we can calculate the annual stroke risk using this score. And importantly, the score being 2 and above, then the risk increases. 2 having 2.2% and 3 being 3.2%, and a maximum score of 9 with 15.2% of annual stroke risk. So how to use this score? So with a CHAD score of 0, it indicates low risk for stroke, where the consideration is no treatment or aspirin. When the score is 1, we have a stroke risk that is moderate, where we consider oral anticoagulation, warfarin with INR maintained to 2 to 3, or new oral anticoagulants or aspirin. When it is 2 or higher, then we definitely have to think of oral anticoagulation, warfarin with INR 2 to 3 maintained, or a new oral anticoagulant. So coming to the new antithrombotic agents. So this is the cascade, the plasma clotting cascade. Here we can see the important newer anticoagulant agents are the apixaban, rivaroxaban, dabigatran. So apixaban and rivaroxaban acting on the factor 10A, and that causes the conversion of prothrombin to thrombin, and dabigatran acting at the level of thrombin. Whereas we also have the other agents that are the antiplatelets, that is aspirin, clopidogrel, and prasugrel, that act at the level of thromboxane A2 and help in platelet aggregation. So our trial is about apixaban. It is a direct acting oral anticoagulant that has an excellent risk-benefit profile for stroke prevention among patients with clinical atrial fibrillation. It is highly selective, orally bioavailable, and reversible direct inhibitor of free and clot-bound factor 10A. It has no direct effect on platelet aggregation, but by inhibiting factor 10A, it indirectly decreases clot formation induced by thrombin. So the bioavailability is about 50%, protein binding 87%, metabolized by CYP3A4, CYP3A5, and CYP1A2 and others. Elimination half-life is 9 to 14 hours and excreted through the bile duct and kidneys. So coming to our article for today is apixaban for stroke prevention in subclinical atrial fibrillation. It is the Artesia investigators. This article was published in NEGM on November 12th of 2023.
I'll just like to put in a word.
Yeah, that's true. Please do.
Yeah. Now this is in patients who have any cardiac issues and who have an implantable pacemaker in which we've been able to detect subclinical atrial fibrillation. So this set of patients is different from the patients that we see as neurologists who usually already have a stroke when they come to us, and then we treat, check if they have atrial fibrillation or not, and then we decide to treat. So at the onset of the article, I would just like to emphasize that this is a trial about primary prevention of stroke, not a secondary prevention of stroke, which is what we are usually used to and what we do in daily practice. Goti sir, would you like to add anything else?
Yeah, actually, whether it is important, pertinent for us to look for any episodic paroxysmal atrial fibrillation and to treat with oral anticoagulation in patients who have stroke risk factors. That's not our routine practice, but this trial has given some clue towards that, whether it is useful or not. I think we'll discuss the article and then we'll invite comments from others.
Yes, sir.
So first coming to the trial design, it is a prospective multi-center double-blind double-dummy randomized controlled trial. It was conducted in 247 clinical sites in European and North American countries with inclusion of majority white European population. They had about 94.1%. It was conducted from 2015 to 2021, funding majorly by the Canadian Institute of Health Research and also by Population Health Research Institute, Bristol Myers Squibb, Pfizer and Medtronic. So first let's see the inclusion criteria. So the trial included patients who had a permanent pacemaker or defibrillator with atrial lead or a single chamber device with AF detection algorithm like those employed in implantable loop recorders or insertable cardiac monitor capable of detecting subclinical atrial fibrillation. Patients at least had one episode of device-detected subclinical atrial fibrillation that lasted for more than 6 minutes and no episode more than 24 hours in duration at any time prior to the enrollment. Patients had an age more than 55 years. The risk factors for stroke included either previous stroke, TIA, or systemic embolization. Age more than 75 years old, 65 to 74 years old with at least 2 risk factors, and 55 to 64 years old with at least 3 risk factors. The risk factors being female gender, hypertension, heart failure, diabetes, and vascular disease. Coming to the exclusion criteria, it included clinical atrial fibrillation documented by a surface ECG that lasted for more than 6 minutes with or without clinical symptoms. Patients with mechanical valve prosthesis recent within the past 6 months DVT or pulmonary embolism or any other condition requiring treatment with an anticoagulation. Patients who are allergic to aspirin or apixaban. Patients who had severe renal insufficiency, a serum creat more than 2.5 or a calculated creat clearance less than 25 ml per minute. Patients who had serious bleeding in the last 6 months or at high risk of bleeding. That included patients with bleeding diathesis. And patients who had moderate to severe hepatic impairment. Also, patients who had ongoing need for combination therapy with aspirin and clopidogrel were excluded. Ongoing need for strong dual inducers of both CYP3A4 and P-glycoprotein, that is rifampin, carbamazepine, phenytoin, they were excluded. Patients who received an investigational drug in the last 30 days. Participants considered by the investigator to be unsuitable for the study for any reason. Patients who had life expectancy less than 2 years due to concomitant disease. And women who are pregnant, breastfeeding, or of childbearing potential without an acceptable form of contraception in place. Next, coming to the randomization and intervention. So the patients underwent randomization by an interactive web-based randomization system. It was located at the Population Health Research Institute. The randomization was done in a 1:1 ratio between aspirin and intervention therapy with apixaban in a double-blind, double-dummy fashion to receive either apixaban at a dose of 5 milligrams twice daily or aspirin at a dose of 81 milligrams daily. So if subclinical atrial fibrillation lasted more than 24 hours or clinical atrial fibrillation developed, then apixaban or aspirin was stopped, follow-up was continued, and treatment with an open-label anticoagulant was initiated. So here we can see the flow chart. So patients with subclinical AF, at least one episode more than or equal to 6 minutes, but none more than 24 hours, not on any oral anticoagulant, and with risk factors for stroke. They were randomized into two groups. So it was double-blind, double-dummy design. So the groups are placebo aspirin OD with active apixaban 5 milligrams or 2.5 milligrams BD. This reduced dose was only for patients who had an impaired creat clearance. And the other group was active aspirin, where they received 81 milligrams OD with placebo apixaban BD. So approximately 4,000 patients in approximately 230 sites. So the follow-up visits were done at 1 month and every 6 months until 248 primary efficacy outcomes were attained. That was an average of 3 years. So coming to the primary efficacy outcome and the primary safety outcome. Primary efficacy outcome was stroke, including TIA with imaging and systemic embolism. And primary safety outcome was major bleeding. So this is the randomization and the follow-up of the participants in the intention to treat population. So the ITT population, there was a total of 4,012 patients. They were randomized to apixaban that had 2,015 patients and aspirin that had 1,997 patients. Among the apixaban group, 26 did not receive the study drug, and out of that, 1,989 patients received allocation intervention. Among this group, 457 patients died, 32 were lost to follow-up, and 17 patients withdrew their consent. So finally, we had a number of 1,509 patients in the apixaban group. Whereas in the aspirin group, there were 25 patients who did not receive the drug. 1,972 patients received the allocated intervention. 438 patients died, and 33 patients were lost to follow. 19 patients withdrew consent. And finally, we had 1,507 patients in the final visit completion. So what are the reasons for drug discontinuation? It was either due to patients who developed clinical atrial fibrillation or subclinical atrial fibrillation that lasted for more than 24 hours. This included 490 patients. Patients who had atrial fibrillation on ECG were 176 and subclinical AF was 340. The various other reasons were physician's decision, participant decision, patients on oral anticoagulation for other indications, bleeding, renal function, and those who are ineligible. Coming to the baseline characteristics among the two groups, if we see in general, overall the baseline characteristics were similar among the two groups. We can see that there was only about 36% of female sex patients. Most of the patients included in the study had an implanted pacemaker. That was 70.2% versus 68.6% respectively in both groups. Here we can see the mean Chadwa score was 3.9 between both the groups. However, 60% of the patients included in both groups had a score higher than 4. If we see the ethnicity in this, it is clearly seen that white European population was the majority of the patients. They formed about 94.2% in total. And there was also patients who had baseline antiplatelet use. So we can see aspirin, there was a baseline antiplatelet use of aspirin of about 57.8% in the apixaban group and 56.9% in the aspirin group, and total of 57.4%. Coming to the efficacy outcomes. So the primary outcome was a composite of stroke and systemic embolism. So with the development of subclinical atrial fibrillation lasting more than 24 hours or clinical AFib, the patients would become ineligible for the trial. And the stroke severity was assessed with the use of MRS at the next scheduled follow-up visit that was occurring after a stroke. So the primary outcome measures were stroke and systemic embolism. That was a composite of both. So they have defined stroke in the trial as rapid onset of a focal or global neurological deficit with the duration lasting more than or equal to 24 hours, or the neurological deficit results in death, or the neurological deficit is supported by clear evidence of cerebral infarction or diffusion-weighted MRI imaging, with no other readily identifiable non-stroke cause for the clinical presentation, and confirmation of the diagnosis by specialist evaluation or brain imaging procedure. Systemic embolism was defined as clinical signs and symptoms that were consistent with embolic arterial occlusion, plus at least one of the following, that is, surgical report indicating evidence of arterial embolism, pathological specimens related to embolism removal, imaging evidence consistent with arterial embolism, or autopsy reports. The safety outcome measure was major bleeding, and this was the main safety outcome, and it was as per the ISTH criteria that included fatal bleeding or symptomatic bleeding in a critical area or organ such as intracranial, intraspinal, intraocular, retroperitoneal, intra-articular, pericardial, or intramuscular with compartment syndrome, and or bleeding causing a fall in hemoglobin level of 2 grams per deciliter or more, or leading to transfusion of 2 or more units of whole blood or red cells. So here we can see the primary outcome, that is stroke or systemic embolism. So the primary outcome in the apixaban group, it was 55 patients. So that was 0.78% per patient year. And in the aspirin group, it was 86 patients. That was 1.24% per patient year. In this graph, we can see the clear difference between aspirin and apixaban. With the cumulative incidence that was much higher in aspirin, the hazard ratio of 0.63 and a significant p-value of 0.07, with apixaban showing lesser number of patients with stroke or systemic embolism. This is the clinical outcomes, the intention to treat population. So the stroke severity was assessed, and here we can see about 33% of stroke in the apixaban group and 43% in the aspirin group. The risk of disabling or fatal stroke was lower by 49% with apixaban than with aspirin, the hazard ratio being 0.51. Deaths were similar in number between the two groups, with total number of deaths with 362 in the apixaban group and 341 in the aspirin group. Major bleeding in the intention to treat population occurred more often with apixaban than with aspirin. So major bleeding, we can see that the number was 106 in apixaban and 78 in aspirin group. This was also significant. Coming to the primary safety outcome, already mentioned about this, the major bleeding according to the definition of the International Society on Thrombosis and Hemostasis. The primary analysis of major bleeding involved the on-treatment population. The risk of major bleeding was 1.71% per patient year with apixaban and 0.94% per patient year with aspirin, with a hazard ratio of 1.80. So here we have a table where the clinical presentation and management of major bleeding is shown. So the number of major bleeding events, apixaban having a higher number with 93 and aspirin with 49. So clinical presentation with hemodynamic instability was uncommon, and most bleeding events responded to supportive care, which could include red cell transfusion. Fatal bleeding occurred in 5 patients with apixaban and 8 patients with aspirin. Symptomatic intracranial hemorrhage occurred in 12 patients with apixaban and 15 patients with aspirin. So coming to the analysis, the Artesia trial showed that among patients with episodes of subclinical atrial fibrillation and risk factors for stroke, the risk of stroke or systemic embolism was lower by 37% with apixaban than with aspirin, and the risk of disabling or fatal stroke was lower by 49%. The risk of major bleeding in the on-treatment analysis was increased by a factor of 1.8 in the apixaban group as compared to the aspirin group. The trial was not powered to analyze subgroups. So coming to the critical appraisal. So what is the research question here? So in the PICOTs, so the patients were all consenting patients above the age 55 years with a permanent pacemaker or defibrillator or insertable cardiac monitor capable of detecting subclinical atrial fibrillation with risk factors of stroke. The intervention was administration of apixaban. The comparison group were patients who are taking aspirin. And the outcome was to assess the occurrence of stroke, systemic thromboembolism, and major bleeding. And the time duration was of 6 years. Coming to the external validity, so the sample population has well-defined characteristics which cannot be directly extrapolated to other populations. The study it conducted mostly was among white Caucasian population. Setting was natural environment. So the sample size calculation, it was based on a similar previous study, the AZURE trial, where the annual rate of stroke and systemic embolism was 2.75%. So assuming an event rate of 2.75% per year in the proposed population, with an anticipated mean follow-up period of 3 years, and using a two-sided significance level of 0.05, a sample size of 3,719 was required to provide 80% power to detect a 35% relative risk reduction, allowing for combined dropout and crossover rate of 8.5%, and the occurrence of 248 primary outcome events in both groups. So in this study, they finally enrolled 4,012 patients. So was the trial of sufficient duration? Yes. It was from 2015 to 2021, 6 years. There was an early termination after a mean follow-up of 3.5 years owing to slow recruitment and a lower than expected event rate. So the study results were not affected by conducting study at any particular time. So coming to the internal validity, was the randomization process clearly described? Yes. So patients underwent randomization by interactive web-based randomization system located at the Population Health Research Institute, and it was in a 1:1 ratio to apixaban and aspirin groups. Were the groups treated equally apart from the experimental intervention? Yes. Was blinding used? So they've used double dummy, double blinding method. Is the data on attrition? Has attrition been adjusted in the analysis? Yes. The data on attrition has been mentioned. Many patients were removed from the trial during follow-up as they developed subclinical atrial fibrillation that lasted for more than 24 hours. There was 490 patients in the apixaban group and 476 patients in the aspirin group. Many patients stopped medication for unknown reasons. That was 687 in the apixaban group and 697 in the aspirin group. During follow-up, there was death in 457 patients in the apixaban group and 438 patients in the aspirin group. 61 patients in the apixaban group and 57 in the aspirin group were lost to follow-up, and attrition has been adjusted by using the intention to treat analysis. So this is the table with A being 55 patients in the apixaban with stroke and embolism as outcome, B with patients with no stroke or embolism in the apixaban group, aspirin, C being aspirin showing stroke and embolism, and D with no stroke or embolism with aspirin. So we had a total of 141 patients who had stroke and embolism, systemic embolism, whereas 3,871 patients with no such outcome, and a total of 4,012 patients. So the control event rate here calculated was 0.043, experimental event rate of 0.027, absolute risk of 0.016, and relative risk of 0.63. And we got a number needed to treat of 62.5 for apixaban.
Shrihari, can I just explain this table? So this is a 2 by 2 table which we can derive in any control and experimental study, in any treatment study, especially a randomized control trial. So we have the intervention, which is drug. So those who are getting apixaban, that is the intervention drug, and those who are getting the placebo or the baseline old treatment, which is aspirin. This is on this column over here. In the row above, we have patients who have the outcome. So the primary outcome of the study is those who have stroke or embolism. So these are things that we want to prevent. So which patients have got these things, and those who haven't had any of these events, so haven't satisfied the primary outcomes or have been prevented because of our drug, come in this second column. So as you can see, all the numbers add up, and in order to prevent stroke or systemic embolism in a patient with subclinical atrial fibrillation, we need to treat 62 patients or around 63 patients with apixaban to prevent one outcome, which is stroke or embolism. Gorthi sir, would you like to add anything else to this? Or Srihari, why don't you continue?
The population is only the selected population which is included. This is applicable. The NNT is applicable to the population like what they selected, those who are on defibrillators and those who are having stroke risk factors. So I think this is a very high NT, and we'll ask the faculty to comment. But I feel though it is very encouraging, but the NNT doesn't tell us to pursue this line. We can conclude and then ask for the comments.
Yes. Were all the relevant outcome factors considered? Yes. Are our patients similar to the target population? No. Will the intervention help our patients? So in patients with subclinical atrial fibrillation and a high Chadwick score, apixaban would help prevent stroke more effectively than aspirin. So what are the limitations? So the calculation of sample size for the trial was based on the AZURE trial, where they concluded need for 248 primary outcome events in the two groups. However, as per their data, there are only 141 primary outcome events that were achieved. This trial has only included implantable cardiac devices. We need to study the same after including population with wearable electronic cardiac monitors and direct-to-consumer devices used to screen for subclinical atrial fibrillation. The study is methodologically sound and well executed, but its usefulness in the Indian context is questionable. The trial has not mentioned their limitations. So to conclude, apixaban resulted in lower risk of stroke or systemic embolism than aspirin in patients with subclinical atrial fibrillation. This included a substantial between-group difference in disabling or fatal stroke. The risk of major bleeding was higher in apixaban than aspirin.
I think, Dulari, you can ask the faculty to opine before you conclude.
Yes, I would like any of the faculty or any of the participants who would like to make any comments on the study or on our interpretations of the study.
Asmita, you can unmute the participants, and I would like Dr. Dhamija and Dr. Anand.
Okay, sir.
Yeah. Any other faculty who wants to contribute, please come forth. Anand, Dr. Dhamija, sir, would you like to comment?
Can you hear me? This is Dr. Anand.
Yeah, we are here.
Yeah, so I think, and I agree with, I think the previous slide when he says in our context, I think it's fairly limited. I remember when I read this trial, this was a couple of weeks ago, the first knee jerk was positive, because we have had navigate ESUS, respect ESUS, and then the Artesia. But then if you look at it, 55, versus, I think the number needed to treat at 1 year is you're talking about 1 in 200. And mind you, again, in the context of, where we don't have implantable loop recorders. I don't know, probably in Pune or some of your better places, you have implantable loop recorders, we not. So I think even though on the first look is that the trial is positive, encouraging after at least 3 negative trials that I just mentioned, I think I was probably not very helpful because a number needed to treat of 1 in 200 with implantable loop recorders. And so that's number one. And second thing, we know anticoagulation versus aspirin for secondary prevention in patients with atrial fibrillation. So not very practical. I think the numbers 1 in 200 at 1 year, I think on sitting down was not too happy about it. I don't know. How applicable can it be, especially for our setting?
No, ever since the Novaks have come into work, there is a lot of excitement in everybody to try them in various types of situations. And this is one of them, I think. And I think, Anand, I share your view that we should not recommend this type of intervention. I don't know how frequently we do test for subclinical AF in a patient with stroke with risk factors, and how often you do it.
So honestly, I do not have, the capacity to do, put implantable loop recorders. So that's my one thing. The 7-day halter, if you look at 1-day halter is being done, but again, the yield is very low. Even a 7-day halter, you're talking about 2%, 2 out of 100. So honestly, I think and maybe it's our practice setup, I think, and if you look all over the world, we also realize that in the past, in the say 80s and 90s, we are talking about red and white clots. But I think if you realize that it's probably a mix of both, and I think even the Artesia trial, it's not Artesia, Arcadia, I always get confused, the one which looked at pro-BNP and atrial cardiopathy, I think we realize that the answer is probably not very clear. So maybe either the ESUS concept is probably, I think, too generalized. I think we probably need to tone down our excitement. And I think even if you look at, what we have started doing is combining, an aspirin along with, a NOAC in those, sort of ESUS construct patients, that's what I do. I don't have long-term loop recorder, available with me to comment more than 7 days. So the yield is very low.
Actually, we do a long-term external loop recorder for 7 days, but I didn't achieve any good result with that. And to tell you truth, it's waste of money.
Yeah.
Any other faculty, Dr. Dhamija sir, would you like to say?
Yeah, I think it is a good study. Only problem is that the patient follow-up is a very difficult in most of the cases. Number one. Number two, there is a slight difference of opinion between the cardiologist and the neurologist.
Sir.
Any patient which is referred to them, they will write this drug. Whereas you think that we should not put the patient on the drug.
Yeah. Yes.
Because ultimately, you see, if the patient is admitted under your care and the patient gets a hemorrhage, you are to be blamed, not anybody else. That is a point. I think a more elaborate Indian study has to be done in a situation like this. Thank you.
So attendees, Dr. Dhamija is a senior most neurologist, and he's a very good academician. And I am very happy sir has joined to give his opinion. Thank you very much, sir.
Thank you.
Somebody wants to talk. I think some hand was raised. You can, I think, Asmita, you can unmute them.
Oh, thank you, sir. Thank you. I have just queries. I am not commenting on the study. That what about the aspirin dipyridamole combination as against this aspirin versus this apixaban?
I think Anand, would you like to answer?
I think it is more beating around the bush than not. I think and again, we are here talking about anticoagulation issues. So I don't think
Thank you. Okay, done. Okay, done. Thank you.
That's nice.
Thank you.
So, any other participants would like to ask any question? Please come forward so that it's time for us to discuss.
Just one more question. Can I ask, sir?
Yeah, please.
Sir, we see in routine practice that with short history of confusion, old age patients, diabetic, the periventricular white matter ischemic changes are seen. And in those patients, if we give low molecular weight heparin as against the tenecteplase, the patient responds better.
This, I think, we don't use that way for periventricular white matter hyperintensities. They are ischemic demyelination, and
yes. If there might be, if there is some pontine ischemia or otherwise, should we go for tenecteplase or we should go with enoxaparin?
No tenecteplase unless it's an acute stroke with large vessel occlusions and time frame is there. But low molecular heparin only helps in preventing the propagation of thrombus. Already ischemic demyelination is there. You should not give. Antiplatelets can be considered to prevent further development of ischemic demyelination. Anand, please opine.
No, I agree with it. I think so. I think one of the main issues with I think strokes in milder deficits has always been, I think it goes along with the line of forgive thrombolysis to everything. But I think if you look at the two trials, the Aramis as well as the Pooja Khatri trial, I think strokes in milder deficits, I think the verdict is still open in the sense. And if you look at Chance Point, So I'm not.
No, actually, we did a Dr. Prasad ke saath, we had dual antiplatelet therapy in milder strokes and TIAs. We did I think systematic review and meta-analysis. It is recommended right now. After that, up to 21 days, we give dual antiplatelet therapy, not beyond that. That's what the practice. It's published in BMJ Open Access. People can read on that.
So can we, sir, just another question is, there is some molecule which is propagated by pharma companies, sovataltide.
Yeah,
Hello?
yes. You can type, spell the name again.
Sovataltide is the salt
Yeah,
and
yeah.
trival. Yes,
Yeah.
sir.
Yes, Anand,
Yes.
I got no faith in this, but Anand can opine.
So no use, no use.
No,
Okay, sir.
same. I agree with Dr. Gorthi. Very limited, small trial. I think they've been able, and how they got it approved. Let's not talk about it.
Okay, sir. Thank you. Thank you. You have told me. You have answered the question. Thanks, sir.
Hello, am I audible?
Yes, yes.
Sir, two things I want to point out that DAPT is advised for 21 days in patients without LVOT and for 3 months with LVOT.
That's correct. It's an intravenous stenosis. The trial is going on right now. Up to 1 year, we are doing the trial in stenosis, which is funded by ICMR, and the results will come later. But right now, intracranial stenosis we do for 3 months. But extracranial stenosis, there's nothing. There's a TIA and minor strokes. We are giving only for 21 days.
And secondly, sir, if you see these bleeding manifestations with apexaban, they are very not large ICH. In fact, aspirin has landed with more ICH with if we compare with apexaban.
And that's true. In this study, it appears that way. That's correct. The hemorrhage is more with aspirin.
More with the So and thirdly, the population which they have chosen is already compromised. So already they are at a very compromised position. So I think we need some better studies. So in our patients in which they are without much risk factors, in which Shad-West score is less, then we can try apexaban. I think then the NNT can be low. I think so. If I am
But
correct.
as Anand has pointed out, all these studies which ESUS has been tried, and ESUS studies, they're all negative studies. So far, apexaban has not proven effective in any of these studies. So still, I think we have to wait for the verdict to come. But we don't usually look for paroxysmal atrial fibrillation in cases of stroke with risk factors. But we have to do it. We have got only external loop recorders with us, and anybody else can. I think Dulari, you can conclude by saying what is your opinion.
Yeah, I would just like to point out some things. What is primary stroke prevention? So, things that we learn in community medicine: control of diabetes, control of hypertension, living a positive lifestyle, no sedentary activity, means lots of activity and not sedentary lifestyle. So, this is something that we really do not focus as neurologists, and this is what people see, which is the need of the day. Whereas what we focus on is when the patient gets a stroke, then what do we do? So I feel this trial is more important for cardiologists who are likely to follow up these patients with subclinical atrial fibrillation because they have an implantable pacemaker which is detecting it. Neurologists are less likely to see these patients till they actually develop a stroke. What we need in India is to find out if they have already had a stroke, they do not have atrial fibrillation, but they might have risk factors for it. Elderly or say a Chad-Wast score of 1 or so. In them, if they develop subclinical atrial fibrillation, how much more would aspirin be better or anticoagulation be better? Am I able to make the difference?
Yeah. I think you are correct. In those patients, as suggested by Dr. Jiten Sharma, apexaban stands a better chance because it's causing less intracranial hemorrhage if we are able to identify. One thing is clear that the 24-hour Holter is useless.
Yes.
48 hours is useless. What we should do is.
Yes, sir. Even in daily routine, we find nothing comes out.
Yes. One more thing I'd like to say is that they have looked at as atrial fibrillation as a continuum. There are patients who don't have atrial fibrillation. There are those who have a pacemaker, and so you have been able to detect subclinical atrial fibrillation, and those who have overt clinical atrial fibrillation. So amongst this population that they have studied with subclinical atrial fibrillation, 1/4 of them in each group. So they've taken about 2,000 patients in each, and almost 500 in each group within the study period have developed clinical atrial fibrillation, or the atrial fibrillation has lasted more than 24 hours. So they have decided on anticoagulation. 1/4 of them, for whatever reasons, have stopped the medication in both groups, and 1/4, because this is an elderly population, have died. So actually what results we have only of 1/4 of the remaining patients who continue to take the medication for the 3.5 years of follow-up. So I feel that's also significant that this population, though we are not exposed to them, we are not picking them up with our current setup in India, they are likely to develop clinical atrial fibrillation in like 1/4 of them in the course of 6 years. And then there is no controversy, they definitely need anticoagulation. Any comments or any?
Yes, perfectly right.
There's a question about the dose of aspirin in secondary prevention in young without any cardiac involvement. Would anyone like to answer that?
The dose is about 81 milligrams, 75 milligrams, 150 milligrams. This is the dose that is usually used for secondary prevention, not the 325 milligrams. Any other questions?
Hello, sir. Can I ask, sir?
Yeah.
Sir, I am not a proper neurologist, but I worked under some neurologist. He was from US, here in the Amritsar. And I worked with him for 20 years. And he used to put 325 TDS for first 7 days, then 325 for proper for 7 days, then 7 days. Although reducing that 325 after each 7 days, and the results were very encouraging.
So far, there is no evidence for such high doses.
Yes, without any connectablase or alteplase, the results were same. And even studies are there that at 1 year they are same.
We can't endorse this recommendation, isn't it, Anand?
Yes, I agree. I think we need, hard data, I think what was the, I think the PICO question, so unless the data is published or we know in a PICO format, how do we know? So yeah, I agree with Dr. Gorti. Yeah.
You cannot use it.
There's another question, role of loading dose of dual antiplatelets in stroke.
Yeah, in TA and minor, we are loading with 600 milligrams clopidogrel as advised. And also, there's no loading dose for aspirin. We continue the normal aspirin dose. So loading doses for clopidogrel as per the BMJ open access meta-analysis, which we published, Dr. Prasad published.
Yes.
We have a very interesting conversations. Anything else? If there are no other things, I think any other comments from the faculty before we wind up?
I think I have one comment unrelated to this, that I have to commend Dr. Gorthi, because I think, small town doctors like me, we never get an opportunity to discuss this article. But I think the effort that you take on behalf of the Indian Academy of Neurology, I think it's commendable. So I think you and whoever helps you out. So I think, thank you.
Thank you very much.
It's probably it's probably, thank you. That's all I wanted to say. I think it's not easy work, but you do a great job. Thank you, sir. Thank you.
Thank you, Anand. And thank you all the faculty. Dhamija sir, thank you very much. Dulari, thank you very much. And Srihari, thank you very much. I think we'll say good night to you all until the next General Club in the next month and New Year.
Okay, bye-bye.
Thank you, sir.
Bye, sir. Bye.
Enjoyed the article.
Thank you, sir. Thank you very much. Okay, then. Good night.
Good night.
Bye. Good night.
Bye. Good night. Bye.